listening to CMDA Matters, the weekly podcast of Christian Medical and Dental Associations. Here's your host, Dr. Mike Chupp.
Well, welcome back, CMDA Matters listeners. I sure do hope that you listened to last week's program because we released the first part of a timely interview with Dr. Michael Laidlaw. He's an endocrinologist who has been in practice for 18 years in California. If you did miss it, let me suggest that you just hit pause on this episode and go back to give last week's episode a listen. There was just so much good information for you, our listeners, dealing with the side effects and the complications and the physiological impact of cross-sex hormones and puberty blockers in gender-confused kids. So we broke it up into two parts. The second half of our discussion with Dr. Laidlaw concludes today with a poignant discussion on the way forward for the House of Medicine. If indeed we are going to protect our beloved profession from gender ideologues, our behaviors, friends, are going to have to change. So let's jump right back into our recent conversation that Dr. Jeff Barrows and I had with Dr. Michael Laidlaw about the increasing body of evidence documenting the impact of these harmful treatments in children and adolescents. Michael, we began this conversation by Jeff talking about the Scrimeti case, which started here in Tennessee. And I would say most of our stateside listeners are going to be familiar with the fact that many have said this is the most important case that went to the Supreme Court during this particular quarter or season of the court's activity. We have many international listeners, and so some of them will not be familiar with this case. But you were an expert witness at some point in time in this case. So I assume you've had a chance to listen to some of the arguments or at least excerpts from some of the dialogue that happened between the attorneys and the justices. So what was your take on the case, the argument as it was presented at our Supreme Court?
Sure. Yeah. So I continued to be an expert witness on this case. Everything is on hold in the state of Tennessee while this has worked its way up to the Supreme Court, and I think they're predicting a decision maybe like in May or June, so we don't know exactly what's going to happen. But basically, we have a ban on these types of the gender affirmative therapy that I described earlier, particularly puberty blockers and hormones. I don't think they're contesting the surgeries in this case. And so the question that's come before the court really is, and as this happens, in the United States, once you get to the Supreme Court, they're often arguing about what we call a very narrow slice of the law. And in particular, the question is, do people who identify as transgender have a special classification as their own sex? And is that sex being discriminated against? That's really what the Supreme Court is looking at. Now, the questions, if you listen to it, are much more broad, coming from the different justices. And they mentioned the Cass review and things like that. But really what they're looking at is this very narrow, legal angle. And so, I'm not an attorney. I won't comment on that in particular. But, advocates for the other side would like to say that this type of treatment is, of course, beneficial and helps people's mental health and helps reduce suicides and has no the harms are minimal. And we're saying, I've been saying the opposite, that the harms are indeed great. We don't have good data about this. And, I might be jumping ahead a little bit, but, I think one of the things that the arguments that they're trying to make is that most of these kids who have a gender identity that's incongruent with their physical sex will remain that way. If they're identified during puberty, they'll remain that way until adulthood. And that just contradicts what I said earlier, where the majority, 90% or more, will actually desist. And so if you look at this, what's happening is that the cases they're using, the type of studies they're using to prove their case, majority of those kids, they're being given puberty blockers, they're being given hormones already. And so their desistance studies, which they point to, are not showing what I call natural desistance. They're showing what happens to kids who are already put on these treatments, which is not an intelligent way of looking at it. And that's what the Dutch had shown in the De Vries studies going back in the early 2010s, that I think all of them in this group of 70 who started on puberty blockers and hormones remained on those by the end of their study. And then the majority of those went on to surgeries, which in those cases removed their genitals and became sterilized. And one person died of necrotizing fasciitis, or flesh-eating bacteria, from that study. But to me, all that shows is that once you, to put it bluntly, once you start drugging kids and young people, because these are drugs, right? I mean, particularly when you talk about testosterone, this is a DEA-regulated substance. You guys may know that you have to use your DEA credentials. You know, I have to sign in. If I'm doing it electronically, I have to type in my code and everything like that to ensure that just a male getting testosterone can get it. So the psychotropic effects of these medications, in my estimation, interfere with the ultimate outcome of desistance or not. And if some young child has puberty blocked at age 10, they might think, well, really, I guess I won't turn into a boy after all, because look, I look like a girl when I put a dress on. But they don't have enough knowledge to say what's going to happen to them in the future. And so, in my estimation, they're locked in. And so they use these type of studies to prove their case, but it's the wrong types.
You mentioned that they get on a path, once they have hormones or surgery, that they're on a path and they don't desist. But doesn't it suggest that even social affirmation tends to set them down on a path from which they don't come back? So it even is prior to that. Jeff, is that right?
Yeah, and that's a point that I think is important to make, because a lot of people would look at social transition as relatively benign. Mm-hmm. It doesn't involve any medication. It can be reversed. But in actuality, when you look at it, it's just the first step on the treadmill. And therefore, when you look at the kids that undergo social transition, it's not benign, because they tend to continue down that treadmill. Mm-hmm. So with that, Michael, we've talked a little bit about the Cass review, which had its final iteration released in April of 2024, and it's sent shockwaves, I think, through not just the National Health Service of the UK and also here in the West, but across Europe. So it's often cited and even mentioned in the recent Supreme Court case. So could you summarize a little bit of the conclusions that Dr. Hilary Cass, the main author of that review, in terms of what they found in terms of level of evidence on gender affirmation care?
Sure. So Dr. Hilary Cass is a pediatrician in the UK, and they spent the last several years looking into the evidence base for gender transition to inform the National Health Service over there about the best way to go forward with helping kids with gender incongruence, gender dysphoria. And part of what they did was the York University did what we call systematic evidence reviews, where they taken as much data as possible or studies as possible, say on puberty blockers, and look what sort of good evidence do we have to show that this, for example, resolves gender dysphoria or helps to alleviate anxiety, depression, so forth. In doing so, several things. First, as background, they found that there was a large increase in kids being referred to their what they call the Gender Identity Service, which is centered around the Tavistock site. And they found that whereas earlier on, I might be messing up the exact dates, but say 2009, where they had 50 referrals, this had increased some like 4,000%, I think, by the late 20-teens, if you want to call it. And why was that the case? And they were also seeing a shift from mainly males to being majority females coming into the site. And they had seen that in other places in Europe, like Finland as well. And so they were looking for reasons for that and looking to look at the evidence base. And in a nutshell, they found what those of us who have been working in this for some time already knew, that the quality of evidence was poor. And I would say the quality of a lot of the studies was poor. It's not high quality evidence, what you might get from what we call randomized controlled trials. or strong observational studies, they were poor overall. And it's interesting, if you go look at the Endocrine Society Guidelines 2017, you find the same thing. It shows that these are low to very low quality evidence base, or I would also say there's no quality because they just invented stuff and don't have any support. Like, what's the proper reference range to give testosterone to a female for this condition? So they've kind of confirmed these in a very systematic way. And so based on that, they've changed their program insofar as the puberty blockers, they're moving into just only strictly for clinical trial purposes. The hormones, I think they pushed to age 16 or higher. They were not doing surgeries for people under 18 in the UK. But I think some of what they did confirmed what we already knew. But it was good to have, a national health system in this case emphasize the problems and make major changes to their system because of it.
We've been mentioning several times, and for our listeners' benefit, you've been referring to SEGM, SEGM,
Yep.
or the Society for Evidence-Based Gender Medicine. We've had several guests in the past who've referred to them as a pretty good resource, actually, as the name would suggest, focus on evidence-based. And I was just reading last week the lead blog on their homepage of SEGM, and how there was a very strong pushback from a pediatrician associated with Yale and an attorney friend of hers, Dr. McNamara, and some others, kind of posing as representing Yale University and saying that the Cass review has many flaws, and therefore in court saying that the Cass review should not have the influence that it's having on the world, but in particular in U.S. courts. So your thoughts on some of the pushbacks? Is there anything legitimate about the criticism that's been given, especially by U.S. doctors who are gender affirming, so-called? Is any sort of credence to those criticisms?
Well, it's some of it is deceptive language on their part. And one I actually jumped ahead to the desistance. That's one of the claims of Dr. McNamara, I believe. I'm not sure if it's in that piece or in other pieces that, hardly any of these kids desist. When they've looked at studies of what I'm calling natural desistance, the bulk of them were done on 12 years of age and younger. And that's where Ristori and Steensma, I think 2016, you can go to table 1 and you can see a number of different studies, 4 major ones and several other older or smaller ones, showing this roughly 90% desistance. And so they're trying to make the claim, and here's where the language gets confusing. I think they do this deliberately. So there's 2 ways of looking at development as I see it. One is a physical development of the person, which, in medicine, we mark this by Tanner stages, where you look at specific changes of the genitalia, say male testicular growth or female breast development, and you can come up with a stage of the development where Tanner stage 1 is prepubertal and Tanner stage 5 is full adult development, and then 2 is the beginning of puberty, and 3 and 4 are stages of puberty. So this is a fairly objective way of looking at a person and gauging what stage of pubertal development they're in. And then there's the psychological definition. I'm calling a psychological definition of adolescence, which for many psychologists use the age of 12. So you're a child up to age 11 or so, and then you're an adolescent from 12 forward. Now, the thing here is there's a discrepancy. So puberty is not, what I described as puberty does not mean adolescence, because we know that puberty could start in girls as early as age 8 and boys as early as age 9. So you have this window in there of age 8 to, say, age 12, where kids are developing physically, but they may not meet the definition of an adolescent in a psychological sense, if that makes sense. And so these studies, like I said, contain a certain amount of kids from age 8 to 12 who just statistically are probably, some of them are going through puberty, a decent amount of them are going through puberty, who desist. And so what the other side is trying to say, well, once they're an adolescent, they don't desist, and then they confuse that with starting puberty. Once they start puberty, they don't desist. So that's this might be confusing, but that's one of the ways that they, in my opinion, manipulate language in order to make it sound like, oh, well, really, once they start puberty, they don't desist. but that's never been shown. The other thing they often claim is that once they're an adolescent, 12 and older, they don't desist. But if you really dive into their references, they don't have any study to support that. It's expert opinion. So that's one thing. I don't know if I made that clear, but I've tried to explain that to people. But the other argument that I think Dr. McNamara and similar are making is that, well, the CAS review really supports WPATH standards of care when it comes down to it, because after all, they're not, which is true, they're not outright banning puberty blockers or hormones. I don't think that means that they're following the WPATH by that measure, because they're saying it needs to, for example, puberty blockers need to happen within a clinical trial. So it doesn't mean any kid who's there can, get puberty blockers. It is limited to a great degree. It's not completely banned. I probably personally have a difference of opinion with the outcomes or the CAS report, because I don't think any kid should be experimented on with puberty blockers for the purpose of stopping normal puberty for gender transition. I don't think it's ethical. Like I kind of pointed to earlier, a child can't consent to their own ultimate sterility, in my opinion. A child can't consent to mastectomy, for example, where they're not able to breastfeed at age 25, and they do this at age 13 or 14 or 15 or 16. I don't think that a child can or adolescent can consent to these sort of harmful procedures based on ethics. And so that's part of my issue. I'm glad what happened with the CAS report, and I'm glad of its utility, but there are some, holes in it or differences of opinion I have with their ultimate conclusions in that sense.
Before we continue with this week's episode, here's a special announcement for you. Have you encountered a difficult patient care decision at your hospital? Do you have a question about how to maintain Hippocratic traditions within your work as a healthcare professional? We know our members are looking for resources on today's top bioethical issues, and we're here to help. CMDA's Ethics Hotline is an on-call program assisting members who are facing these difficult patient care decisions or questions. The hotline is provided by a panel of Christian ethicists who also formulate CMDA's ethical position statements that are based on scientific, moral, and biblical principles. You can reach the hotline by calling 423-844-1000 or by visiting cmda.org/ethics. Time is running out to register for the 2025 CMDA National Convention in St. Charles, Missouri on May 1st through 4th. Sponsored by Samaritan's Purse, this is the premier event for healthcare professionals, residents, students, and spouses to gather in community together. Our guest speakers include Dr. Eric McLaughlin, Ryan Baumberger, Aaron Hawley, and more. We can't wait to gather together and for God to show us how we can each be a spoke in the wheel for Christ in healthcare. So reserve your spot now. For more information and to register, visit natcon.cmda.org. Let's jump right back into this week's episode.
Well, Michael, some of our members may be aware of a news report that came out in October, just a couple of months ago. And they probably heard of this researcher out in California that had withheld data. And the name of that researcher is Dr. Olson Kennedy. And she had gotten a $6 million grant to study puberty blockers in children that were suffering from gender dysphoria. What happened was that she did not get the findings that she was hoping for, and so she decided not to publish her data. And she's kind of been called out on that. So my question to you is what did the data reveal, and how do you think this is going to reflect on the whole cause of those that are ideologically driven and not really evidence-based care, as we've been talking about a little bit with the CAS review, and those that are pushing this treatment in spite of the evidence?
Well, I'm very familiar with this researcher, Dr. Johanna Olson Kennedy. very early on when I was talking to Dr. Van Mol, actually, he mentioned one of her studies that was highlighted by attorney Jane Robbins in the public discourse, which is the same study. And that was my first question when I read about it. How did this get by an IRB, an institutional review board? How did they review kids getting puberty blockers at this age, which can potentially lead to sterility? How did this get through an IRB? And so I started investigating this, and Jane Robbins and I actually made FOIA requests to the NIH to get the full study protocol, the grant application, so forth. And so just to give you a bit more background on this, initially they received a 5-year, $5 million grant. And then this was extended in 2020. So there's actually a $10 million plus grant for this study. And they said, they claimed there was going to be 2 arms to this study. One was a puberty blocker arm where they're going to follow these kids and get data, psychological data, and then physical data like bone density results, laboratory results, and so forth. And then another arm, which was we call the cross-sex hormone arm, where there's a similar thing. They're going to look at psychological data and improvements in gender dysphoria and physical data and so forth. What's happened is that part of the data was published, you may remember, in the New England Journal of Medicine, with the cross-sex hormone data was published, mainly psychological data, and then they claimed that, guess what, their psychological conditions improved on hormones. This is fantastic. When in fact, the most common side effect or adverse effect that they could find was suicidal ideation. And 2 of the kids in this study died of suicide. They had suicide, which makes no sense how they could claim that there's an improvement in psychological health when 2 of your subjects died in just a 2-year period. So that's one arm of the study. And then the second arm is the puberty blocker arm, where the data, there hasn't been any published results from from following or tracking. They have some baseline data, but they don't have what happened when it's tracked. I think Dr. Olson Kennedy has kind of backed off on this. She wrote a declaration, I think, like an official declaration or affidavit stating that she didn't say she was not going to release the data. So we'll see about that. We had written, and Dr. Malone, who's now of Segum, and I, and Hachi Horvath, who's a detransitioner, had written to the NIH, I think in 2019, with the Kelsey Coalition, asking for a moratorium on this study to the NIH because of the harms that would happen to these kids and the fact that this is not an ethical study. And we got a reply back from the NIH kind of blowing us off, I would say, claiming that, this is just an observational study and they're doing the treatments anyways. And if we don't stop the study, these kids will continue to get, these treatments anyways, and not taking any accountability and not having any oversight for what happened. And I have to say, we warned them, and now there's 2 dead kids that we know of, and we don't know what happened to the puberty blocker group, and I don't know that she'll release the data or not.
Well, you've briefly mentioned detransitioners, and I want to kind of change our focus a little bit on that to really look at the increasing need. So detransitioners, for those that are not familiar with the term, are those that have gone through some level of transition, either hormonal or possibly surgical, and then get through the certain that process, and then they regret what they've done, and they want to detransition back to their biologic sex. And what we're finding is more and more people are undergoing this gender transition therapy. There are more and more that are regretting that. And so we're seeing these detransitioners come out. So my question to you is, we've been made aware that a lot of these people, or all of them, need good medical care. They are not able to get this care usually at the gender clinic. They tend to be rejected at the gender clinic where they've gotten these cross-sex hormones. So they're looking for healthcare professionals that will help them work through the process of things like how to stop cross-sex hormones? Do you taper them, or do you stop them all of a sudden? Do you need to start back on endogenous hormones? So a lot of those questions are out there. There's very little, if any, science on it. So what are you aware of as an endocrinologist in terms of recommendations that might be offered to, for instance, our members that are considering and perhaps taking care of these detransitioners?
I think if to start with taper, if you look at in endocrinology, using a taper is a common thing that most physicians will know, particularly for corticosteroids like prednisone or something given in high doses. And the idea is that if they're on this high dose prednisone for a period of time, if you stop suddenly, the person will develop adrenal insufficiency, which can be, catastrophic. You could end up in the ICU with, hypotensive and in serious condition. You can even die from adrenal insufficiency. So therefore, taper and allow the adrenal gland organ to gradually start producing its own supply of cortisol and mitigate those sort of effects. With testosterone or estrogen, there is no equivalent sort of problem where very low levels will lead to those. There is no known problem where it's going to lead to some sort of fatality or serious injury. But there is, in my estimation, more of a concern with psychological effects that might happen because someone's taking, high doses of anabolic steroids. To adapt to suddenly stop taking these medications and adapt to something wholly new could be difficult. I do know of a detransitioner who just stopped estrogen all at once because a friend said that, hey, you could get blood clots, and he discontinued estrogen, and he did fine. And actually what his description was, he felt like he was coming out of kind of a daze where everything was going along smoothly. And then he looked at himself and said, well, what am I doing here? I've got these painted fingernails and a dress. And he was like dumbfounded by what had happened to him. So that being said, and I'm not offering medical advice, full disclaimer, but I'm just offering my thoughts hypothetically as an endocrinologist. And there's going to be some things coming out about this not too far away, and I'll let you guys know. But it seems reasonable to help treat these people for what they really have. Like if someone's taking high doses of testosterone, they have hyperandrogenism, high levels of androgens. And how could you help those people? Well, by gradually maybe, halving the dose every couple weeks or so that after, 6 or 8 weeks, they've stopped using the medication and it's out of their system for either estrogen or testosterone. I think that's probably a reasonable way to do it. You could prolong it. The problem is the longer you're taking these hormones, of course, the more physical side effects that are going to occur to the body that can't be reversed easily will happen. So I think it's reasonable to half the dose every week or every couple of weeks. Theoretically, that should work okay, as long as they have good psychological support for that.
Thanks, Dr. Laidlaw, for explaining. I know that this is a passion of Jeff's and ours at CMDA to figure out how to provide care for those who are suffering because they're being ignored. I want us to wrap up by looking forward. It's clear as we think about the Cass review, how that happened in some of the other European countries that have national health services that have an ability to kind of back up a little bit and have groups of experts, maybe who don't have conflict of interest, kind of looking at these things like Hillary Cass did. How is the House of Medicine in the United States? How can we possibly move forward and repair the damage to trust, public trust that's coming? Yes, the pandemic had a huge part to play in where trust is right now for doctors. But also this transgender issue, this period of time, this revolution has hurt the trust in our beloved profession. How do we move forward and fix the House of Medicine without a National Health Service commissioning a Hillary Cass? Because the push, and also, Jeff and I were talking about this earlier, if Rachel Levine was in charge of the National Health Service in the UK, would the same thing have happened even in the UK? So I really want to hear. I'm looking for answers from our friends who are pushing back.
Yeah, no, that's an excellent question. And then, opinion is divided on that. I mean, I went the route of, because I think the first legislation to try to ban these sort of treatments was in South Dakota, and Fred Deutsch was a legislator, a very brave legislator over there who helped craft the first legislation. And I I actually flew there and provided testimony because I thought it was important. And I thought, just kind of don't mean to bring it back to me exactly, but like I said, I found I couldn't fight the school board in particular. I couldn't work in the education system, so I'd go to the medical system, and then even working with the medical system, meaning our organizations and such, it seemed like you couldn't make any headway. And it seemed like kids needed help immediately. Like, this needs to stop right away.
Right.
I'm not going to wait 10 years for the Endocrine Society to make a decision, or the AMA or whomever. So my kind of avenue that opened for me was working on these state legislative bans, because at least in those states where, and a lot of them have prevailed at the appeals court. I don't know if everybody knows that, but a lot of them have prevailed in the appeals court. So the bans are in place. So those kids are already getting help in those states, like Tennessee. But what happens in California, where I'm at, that's a tougher question. I'm hoping part of this, because I do believe, and then say, well, what's your evidence for this? Well, I don't know, but probably a lot of us believe that social contagion is playing a role in this. People,
of course.
Kids on the internet, and then I'll get pushed back. Well, you don't have proof, and you don't have this and that. But I mean, everybody sees, who has kids or around kids, or just even as an adult, knows the influence of social media. And, some of these schools that you've got kids like, I don't know, I'm just throwing out a number, like half the number, 40% of the kids are identifying as LGBTIQ plus, whatever. And how does that happen? Well, it's obviously like anything you do as a kid. Well, it's hip to be in this group, it's hip to be in this group. Well, my hope is that with this sort of cases, and that more detransitioners and more lawsuits by detransitioners against physicians, that eventually, it's not hip and it's not cool anymore. And young people realize that this is really destructive to my body. And why would I want to do this? I guess I'm looking more at that avenue rather than expecting the AMA to do a 180, next week. And I don't think that's going to happen. I think it's going to change within society. And then these medical societies will eventually follow along. And hopefully a healthy amount of detransitioner lawsuits will also help. Joanna Olson-Kennedy herself was just sued last week, the one we were referring to earlier. There's a lawsuit against her. So if those prevail and information comes out about what's happening and how destructive these medications are, I'm hoping that's one of the major ways it can help states like California.
I would tend to agree with you, Dr. Laidlaw. I've said before that once the malpractice insurance companies recognize there's so little good evidence supporting this, and they start paying out multi-million-dollar awards to the plaintiffs, I think they're going to stop covering this. And so unless there are some wealthy people that put together some type of an insurance policy, it may be the nail in the coffin, because those that are doing this transgender care will be unable to get any type of malpractice insurance.
Yeah, and cases against the pharmaceutical industry that's producing the puberty blockers. And I know that I've heard from our friend Andre Van Mal that that's also going to have a great deal of impact. It's just of great discouragement to me, Dr. Laidlaw, that again, that's not how academic and evidence-based medicine is supposed to work. We're supposed to have internal discussions on benefit. And I'll just close with this. A friend of mine at a very prestigious university in this country, psychiatrist, I asked him not too long ago, have you talked to the chair of your department about some of these things that have come out and about evidence? And he said, well, yeah, Mike. I went to him a couple of months ago, good friend of his, and said, when are we going to have a departmental discussion about all this evidence that's coming out, not just in the U.S., but around the world? And he said, it is not going to happen. We will not go there. That is the chair of a very prestigious medical university in our country. A refusal to have discussions, which is so embarrassing. I can't believe the chairs of psychiatry departments and pediatric departments, and I've known more than one because I've been traveling around talking on this issue, asking questions. It's so embarrassing. I hope that someday there will be a day of reckoning. We'll have an opportunity within the AAP, within the APA, within the AMA to have these sorts of discussions and realize what a terrible travesty this period of time was in our country, to be pushing ideology, and that doctors and lawyers often don't make good bedfellows together. Final comments, Michael?
Yeah, I mean, just following up on what you said, unfortunately, it comes back to we're up against an ideology, and that's why the professor's afraid or people are afraid to speak out because it's not really medicine. There's medicine involved now, but it's not really medicine. It's an ideology that's being pushed. And it's one where people are afraid to speak out. People are even threatened. I've been threatened myself, and my colleagues have been threatened as well. Us who worked on the South Dakota legislation were threatened, and emails were hacked, and all kinds of stuff can happen. I just got a nasty call last week. So it does take a certain amount of, intestinal fortitude to come up against this. And I think people in academic medicine and those type of places just aren't willing to do it. It may be one of those things where a generation has to pass away and the next generation comes in that saw all the problems and said, we're not going to do it this way anymore. That's sad to say.
Wow.
Don't mean to end on a low note. I mean, if you look at all the state bans and all the progress we've really made in the cash report, tides have turned, so much since I first got involved in this. There's so much great things out there. I think our disappointment to bring you into this is with our medical organizations, and I just don't have a lot of hope for them, to be honest with you.
Well, I just want to thank you, Michael, for your courage in standing up. Without you and some of the others that we've mentioned, it would be a lot more difficult to have achieved what we've achieved, the little steps. Your expertise in endocrinology, your willingness to testify, to help with the states getting these laws, those are tremendous things. And I know it's not something you need to do. It's something you're willing to do and stand up and be shot at in the process. So thank you for your courage in there.
Yeah, thank you both as well. Thank you for highlighting on this and all the work you guys are doing. Much appreciated.
I'm hoping, Dr. Laidlaw, that there will be others out there listening, whether or not they're endocrinologists or pediatricians or psychiatrists, who will be inspired by your example. And again, I think the resource, the Society for Evidence-Based Gender Medicine, lots of good stuff there. Other guests that we've had, just appreciate the stand, as Dr. Barrows has said, your courage and perseverance on this topic.
Thanks so much. I hope it's inspiring to others as well. I'm sure it will be.
Friends, it is so encouraging to me to know healthcare professionals like Dr. Laidlaw are standing up and speaking out about the harms of ideologically not medically driven gender affirmation care in children. And friends, I always put that term gender affirmation in quotes. As we often talk about here on CMDA Matters, courage, well, it's contagious. So thank you, Dr. Michael Laidlaw, for your courage. As Dr. Barrows pointed out at the end, he's been speaking up for these vulnerable children. More and more people are starting to stand up within medicine against this ideology. And a great example of that is something we discussed on the podcast last year with Dr. Jill Simons and Dr. Andre Van Maal. And that is the Doctors Protecting Children Declaration, which was released last summer to challenge the prevailing zeitgeist of transgender activism within organized medicine in our country today. If you'd like more details about this declaration, we have included a link in our show notes for you to listen to that episode and consider signing on to that declaration. And by the way, we've also included a link to that critical CAS report in our show notes today, as we mentioned it several times in our conversation, and we wanted to make it easy for you to learn more. For additional information about this topic, I want to encourage you to check out the CMDA Learning Center. There are a handful of courses available for continuing education credit that discuss this transgender topic. For example, you can find recordings from a conference that we hosted just a couple of years ago with the Hendricks Center at Dallas Theological Seminary, and it was titled Critical Conversations on Identity and Gender. Plus, you can find other webinars that discuss the misnamed conversion therapy, the biblical, theological, and clinical perspectives of the transgender movement, and others. And I want you to know that just for this podcast release, I asked our continuing education staff to upload a brand new video produced by a friend of CMDA, Dr. Julie Hamilton, entitled Counseling Gender Dysphoric Children and Teenagers. I watched this 98-minute video, which was brought to my attention by our CMDA friend and 2023 Educator of the Year, Dr. Andre Van Maal, just this past weekend. And friends, it is dynamite. Now, there's no CE associated with that video, but I think it's very valuable for your viewing and education. All of these courses are free to CMDA members, and I also encourage you to talk about them with your colleagues. You can find these courses and more in the CMDA Learning Center at cmda.org/learning. And as I finish talking about resources, there are a few books in the CMDA bookstore that I know will prove helpful to you. First is a great book, When Harry Became Sally, Responding to the Transgender Debate. Drawing on best insights from biology, psychology, and philosophy, author Ryan T. Anderson offers a balanced approach to the policy issues, a nuanced vision of human embodiment, and a sober and honest survey of the human costs of getting human nature wrong. He introduces readers to people who tried to transition but found themselves no better off. The second book is entitled God and the Transgender Debate by Dr. Andrew T. Walker, which helps us as Christians understand what the Bible says about gender identity. You can find both of these books and many others in the CMDA bookstore just by going to cmda.org/bookstore. Did you know that the month of January is National Human Trafficking Prevention Month? If you didn't, then I hope you'll join us next week for an interview with Dr. Charmaine Brooks, who is the chair of CMDA's Commission on Human Trafficking. She's dedicated most of her career, friends, in healthcare to missions and protecting people who are being trafficked. So you don't want to miss hearing her very special story. As we wrap up, I want to close with a scripture verse that, well, it always comes to mind when I think about Christians in healthcare who are being courageous and standing up to protect children. From the book of Joshua, Joshua 1:9, it reads, "This is my command, be strong and courageous. Do not be afraid or discouraged, for the Lord your God is with you wherever you go." And Joshua, as you'll remember, later in his life, stood firm and told his people, "I don't know what course others may take, but as for me and my house, we will serve the Lord." O house of medicine, and you biblically anchored Christ followers in it, Dr. Laidlaw reminded us that now is the time for courage to play a role, a critical role. What a wonderful reminder for us to follow God's call and be courageous, especially as we seek to protect vulnerable children who are being impacted by the horrors and the dangers of gender dysphoria and the rise of transgenderism in our culture, and unfortunately also in healthcare. So CMDA, let's be courageous, as well as wise and protect kids in our environment. And as we do so, we will bring the hope and healing of Christ to them and to the world. That's what matters to CMDA, friends, and CMDA matters. We'll see you next week, friends, God willing.
Thanks for listening to CMDA Matters. If you would like to suggest a future guest or share a comment with us, please email cmdamatters@cmda.org. And if you like the podcast, be sure to give us a 5-star rating and share it on your favorite social media platform. This podcast has been a production of Christian Medical and Dental Associations. The opinions expressed by guests on this podcast are not necessarily endorsed by Christian Medical and Dental Associations. CMDA is a nonpartisan organization that does not endorse political parties or candidates for public office. The views expressed on this podcast reflect judgments regarding principles and values held by CMDA and its members and are not intended to imply endorsement of any political party or candidate.